So welcome again and back to CVC Frankfurt. This time I did not make any mistake with my cap because 100% of the operators now have the CSI cap, so that worked pretty well here. So we have case number 3, and can I have the slides, please? This is a 63-year-old female patient. She had recurrent vertebral TIAs back in 2020, then a posterior stroke in 2022, which was treated by systemic lysis. She had an occlusion of the left vertebral artery and a stenosis or thrombus on the other side, on the right side. At that time, a PFO was diagnosed and classified as a potential stroke cause. There was extensive discussions with neurologists. Patient strongly prefers to have the treatment of all potential stroke causes, and that's why she is here. And finally, actually, the final decision was kind of triggered by the intervention uroradiologists. Although they are dealing with these occlusions and stenosis in the vertebral circulation, they said, okay, it may make sense to close the PFO in addition to consider treatment of these lesions. She also suffering from sarcoidosis, mild hypertension and diabetes, EKG, Holter, and TTE was normal. And on TEE, she had a typical PFO with septum aneurysm. So are there any questions or comments so far?
Horst Iqbal. At this age, I must say I routinely get a CT coronary angiogram as well to find how much atherosclerosis there is. I suppose this lady probably already has atherosclerosis in her head and neck vessels, it sounds like, so you probably wouldn't add much. But even if you didn't, do you ever do CT coronary angiography to look at the heart as well? There's about a 10% incidence of coronary disease.
Okay, so regarding the brain, everything was done, including CT, and but regarding the heart, they didn't do a cardiac CT. And I mean, she has some disease there, and so she has really competing sources of her events. And it's just we see a trend now that even neurologists say, okay, we are not 100% sure what it is, so let's treat all potential causes, which is not in the guidelines yet, but it is developing into that direction.
The host is
Any other questions or comments?
Sorry. Actually, T shows a very high-risk PFO, but the medical history is very complex. And what kind of medication currently is she taking?
She's currently taking aspirin.
Only?
Yeah.
No anticoagulation or DOAC?
No.
No.
No. No. No.
Horst,
would you treat with anticoagulation in that situation?
Yeah, well, in our patient, our stroke physician is much more easy to start for a DOAC for these kind of situations.
Okay. Mm-hmm.
Horst, this is Christian.
Another question, go ahead.
Yes, this is Christian. Hello,
yeah.
Horst. I would like to point out one issue which is, I think, very important in your case, which is the shift in indications right now to a more comprehensive approach to these patients, in which we do not necessarily only try to find out which is the only case which will be the only cause which would be even impossible many times. So the approach of trying to address all the possible causes of one stroke, and as we also pointed out in a paper, in a consensus paper in the ESC with George and Tayos, where we proposed an approach of looking at multi-causes and complex approaches in these patients. So have you any comment on this?
Yeah, I mean, it's really important that we move into that direction because until now, the PFO has been kind of discriminated. So when you think about the patient with a stroke and he has carotid stenosis and atrial fibrillation, you certainly would treat both. But when the patient in addition has a PFO, then you say, oh no, the PFO doesn't need treatment. And that's not the correct way. So I agree with you, this is something we have to move on.
I have a question.
Okay. I agree with you. For me, I will cross it. even the patient have atherosclerosis or not, because I think the aneurysm is quite significant.
There was a question
Okay,
from
so,
the floor.
There's just before you start, Horst, Bushra's got a comment.
I think it was similar to the last comment. It was specifically around anatomical factors of the PFO and whether that sways you as to whether in a patient who has maybe a multifactorial cause, whether that would actually swing you to think, I'm happy to close or I'm not happy to close. I'm kind of referring to the Pascal classification. Thoughts on that, please?
I could not hear you. Can you repeat that?
What about the Pascal classification?
Pascal classification.
So
Okay,
animals-
Pascal
yeah.
classification. We don't use it. We don't use it. I didn't find it very helpful in decision making because each individual patient is so much different from many factors are not covered there. So we don't use it in our practice, and also our neurologists don't use it.
Yeah, but the host is
What is your
saying,
experience?
if the patient already come to your hospital, it's a much more easier to straightforward to the procedures. But in the world, difficulty is how do we pick up the PFO patient in the routine practice? Is there some advantage or the development in Germany? Recognition, also
Well,
including
as you said, most
recognition
of our
of stroke
patients are
features.
coming. Yeah, most of our patients are going through that process before they arrive here. So all these discussions had been done in other institutions, and then the patient comes to us. That's for certainly easier. And I mean, that may be a reason why we don't use the ROPE score or the Pascal score. So I don't know what the experience is. I mean, you are using it, so is it helpful for you in clinical decision making? I mean, there are clear cases, but many patients have so much specific issues which are not covered there. Like this one, she really wants to have treated all potential causes. That changes the picture, of course. What is your experience?
Okay.
I think they didn't quite get the question. So we do add that score, but actually, as you've given a lovely talk before, where there are many patients outside the guidelines and you have to individualize care. And I've certainly got a group of patients where they're so stressed out about the PFO once it's been diagnosed that the only way to move their care forward is to actually just close the PFO. So I think we should probably ask you to carry on with the case.
Yeah, okay. So I have inserted a 9-French sheath in the groin. I have a multi-purpose catheter here. I will show you how to cross the PFO. This sounds trivial, but actually we get a number of patients referred every year where somebody tried to close the PFO and failed just because they were not able to cross. So the trick is to always rotate clockwise. This must be the region of the PFO. You see, it's not always that easy. So I try to avoid to push too hard to the septum. Okay, now I'm through. I go to the pulmonary vein. This may be appendage. Oops, there it was. This
So
is the
Horst,
pulmonary vein.
you're making that look
Now
very
exchange
easy
for,
for people who don't sort of do it without the TOE there. How do you tell whether you're pushing into an appendage or a pulmonary vein?
I saw that I touched something where I was supposed to go straight forward in the pulmonary vein. That tells me I was in the appendage. But now I'm outside of the heart. Let me move the table a little bit. So that's clearly in the pulmonary vein. This is an Amplatz extra stiff. I'm removing the multi-purpose catheter. I will exchange for a 9-French long sheath. We will use the cocoon device, which is a metallic device, similar like the Amplatz device, but it has a coating of platinum, which is of some interest for patients who have a nickel allergy and
So now
are
you
not suitable for the suture or bioresorbable device. Yeah.
So now you are
Go ahead.
inserting for the lower lobe for the pulmonary vein. So don't you use for the upper pulmonary vein for the insertion site of the guide wire?
The preferred position is the upper pulmonary vein, that's correct. But this one is also doing fine. I mean, I don't expect any difficulties to advance the sheath into the left atrium, so I don't care too much about a stable wire position.
Okay.
But you're right, preferred is the upper pulmonary vein because it gives you a more straight line. But I mean, as you know, and obviously I will pull out the wire anyway before I insert the device, so it's not that important.
Horst, you use
Maybe it jumps.
the catheter to cross the PFO and to search for engagement in the pulmonary veins. But what advantages do you find with the guide wire instead?
That's a good question. Let's go to the upper pulmonary vein here. So I always try with the diagnostic catheter first. I can also make a loop in the left atrium. It's not that important. So usually I don't use a wire to cross the PFO, except when I cannot make it with the catheter, then sometimes I use a straight glide wire to do that. So let me, I want to exchange now the dilator for a wire. I will show you why. This is a little bit tricky, so I'm removing the dilator and the wire. I have a Y connector here. Now I will connect the Y connector to the sheath. Let's stop it here from bleeding. Just 2 centimeters, and then I will re-advance the wire. I'm still in the left atrium. Now I will remove the dilator. So now I have the sheath and the wire in the body. I connect the side arm of the Y connector to my
So Horst, that
manifold.
was just to, what was the point of that maneuver? Could you not have just taken the dilator out?
I will do an angiogram of the PFO with the wire in place. That is the purpose, because we don't use echo in this patient here.
So just for the audience, let's be clear that there's
at
no
least we will try to do
transthoracic,
it.
no
So-
TOE. This is a fluoro-guided procedure you're doing, yes?
Exactly, yeah. So I go to 60-degree LAO. 55 is enough, maybe. Okay. Changing the position of the table, zooming in. Okay, let's give a little puff of contrast. Okay, I'm close to the orifice of the PFO, you see that? And now I do a high-speed injection. High speed means 30 by 20. Okay. So that looks like a small PFO. You can actually measure it. It's probably 4 or 5 millimeters.
So Horst, in this angiography,
do this
how
quickly.
do you, please put in, I can see the very clearly for the septum prime, septum secundum, and some lengths of the PFO tunnel.
So I will show you. I don't see the marker. What's happening with my... There is a marker, okay. Wait a second. So you clearly can see the septum secundum, right? That is the white thing which comes from above.
Yes.
It ends about here. Do you see the marker on the screen?
Yeah.
It's hard to see, huh? A little cross. Okay, now you see it. And this is the other end of the PFO. So we are about, what I said, 4 millimeters. And that gives me enough information. And actually, when we start this angiographic technique, we compared this with balloon sizing, and it's very consistent. So balloon sizing is sometimes 0.5 or 1 millimeter more than what we measure angiographically, but it's very reliable. Okay, that's all I need for imaging. So now let's store this image here.
So Horst, I'm just going to ask Bushra, if she's still in the audience, whether she's collected that data, because she was collecting balloon sizing versus fluoroscopy. I think she's left the room. She knew I was going to ask her a question. She's left.
Yeah, because I said I don't use echo, so that she thought, okay, then I can go for a coffee break, right? 25. Yeah, 25. Or
So,
do you have a smaller
so
one?
Horst, you
18?
don't do balloon
18.
sizing at the currently your practice, no balloon sizing for the PFO. device selection?
In most cases, I do without balloon sizing, yes.
Okay.
If I see the PFO nicely, as in this case here. If there is some uncertainty, if I don't really see the opening and the tunnel, then I go for balloon sizing.
But
So
you
we have
already-
4 millimeters, so I think we can go for a small device, an 18 millimeter device, yeah.
So Horst, just to explain the picture to the audience that you're playing, it's a lovely picture. There's a very dark line, that's just a jet of, could we see the picture again? There's a very dark line that is just a jet of
Fluoro?
contrast running along the wall in the left atrium. Could we see the fluoro again?
Yeah.
Yeah. Could you show us if that's it? And then it must be a very short tunnel because the wire deviates off away from that very quickly. So this is a short and not very wide tunnel, is that right?
Correct, yeah.
Yeah, okay.
It's not a long tunnel, short tunnel, yeah.
Yeah, actually, this is a very good
So I'm just
say,
mounting the
imaging
device
for the,
here. This is-
where is the upper part of the say, roof of the left atrium. That is a very good information for the beginning for the PFO
Yeah.
correction.
So you see the device here now. This is, as I said, a device which looks comparable to the Amplatzer device, a regular metallic device, but it is platinum coated. And this not completely eliminates the release of nickel, but it delays it, or so it reduces it. So there's less risk of problems with nickel allergy. And this is a small device, 18 by 18. I screwed it on the delivery system as always. And now I'm pulling it back onto the
So Horst, is
loading
it
tool.
only the 18 device has 2 equal discs? Because otherwise it's like a crib reform or a uni, isn't it?
The
with 2
others
equal
have
discs?
the regular sizes, so 25 by 18. Okay, so now I will connect this flushing system manifold to the loading tool. Let me flush it here. Okay, then I will remove, I'm still across, I advanced the sheath, so I'm in the left atrium now. Okay, I go out. Okay, and I flush again and connect to the system.
So Horst, just before you pop it out, do you
Okay.
see any value in sort of, once you've inserted the device with the loader, of allowing bleeding back, or there are never bubbles that come at that stage?
Well, I hold it below here, below the 0 level, and I saw some blood coming out, and then I flush during I introduce.
Okay.
So that's the regular technique. Now I'm rotating a little bit clockwise here. I go down with the injection speed to 5.5 or something like that. I think I'm now touching the septum here. Yeah, so you see the deformation of the device. I keep the device in place and pull back the delivery system. And now the right atrial disc is deployed. We can do an angiogram here. Okay.
From the
That looks good to me.
TE, you think that the very highly mobile septum concern about the sizings for your selected.
Good question. So I always select the device based on the diameter of the PFO. I don't care about the septum aneurysm. So I always use the smallest device which is suitable to close the hole. And if the aneurysm is not stabilized, I don't care. So now I'm pulling, before I release, I like to pull a little bit on the system, and then I can release it. Wait a second. So I'm releasing. You saw a lot of
Very
tension
good.
there, but it looks good. Yeah. And we can do another angiogram, although I don't do that routinely, just to show that it's in the correct position. Grab the septum,
Perfect,
secundum,
yes.
and primum. Okay, good. Yeah,
but
that's what I wanted to show you. Are there any questions or comments?
Yeah, now you select for the 18 millimeter device. How about that? In my feeling, the 18 is very rare to use for the PFO closure. What's the difference for the 18 and the 25? Why don't you use the 25?
I go for the 18 when the PFO diameter is less than 5. And I mean, it's just the reasoning, if the smaller the better, because you have less foreign material, less surface to form clot formation, less risk of erosion, so everything is lower. The only risk which may increase is the risk of embolization. But if the diameter is that small, 5 millimeter, then 18 millimeter on both sides should be sufficient.
And Jose, did you have any issue with this technique of sizing with persistent shunts after the closure at more than 6 months? Because I mean, at least even if you use only fluoro procedures, probably you have a very in-depth TOE, before the procedure, because for studying also the thickness of the secundum. How does
if
this?
a patient comes in,
how the thickness of the secundum can change your mind on these sizes?
that's not so much the issue, the septum, secundum, but I mean, all patients have to undergo a TE before they come for PFO closure, because there may be additional ASDs, additional defects. So that's what we're looking for. But most of the patients still come with a TE to us. And in those cases, I don't need another TE on the table unless the quality of the angiography turns out to be not good. But if a patient comes with a, let's say, with a transcranial Doppler only, or with a transthoracic contrast Doppler only, so we only know that there's a shunt, then I do the procedure under TE guidance. Yep. So I don't let them go for an outpatient TE and then come in for the procedure. We do it combined then.
Horst, one more question. Oh,
yeah, so the role for TOE guidance in your procedures for PFO closure is only just for patient identification and not during the procedure, as I understand it, right? And you don't use it for device selection? Unless the angiogram is not sufficient, yes. If the angiogram, and that happens, I mean, if you have a PFO which is bigger and has an even smaller tunnel, then angiography is not a good technique. Then I just see the shunt, but I don't see the PFO. And then I do TE.
So when would you use an ASD device? Have you had those cases where you were not expecting a tunnel that was quite as wide as you might think, and then you've switched over? When would you switch to an ASD device?
Yeah, it's usually when I don't see the PFO on angiogram, then I do a TE. Then I see that it's a big PFO. Then I may choose for. Then I usually go for balloon sizing as well. And if the diameter of the waist is more than 15, then I go for an ASD device.
And what about the shunt at long term with this technique of looking only at the PFO width?
Okay, so I didn't do a systematic study on that. But from my personal experience, I don't see a difference in residual leaks. So actually the angiography gives me the same information as balloon sizing. And again, I mean, all these patients had a TE before. So I'm not losing anything really. Okay. But it makes the procedure much faster, and patients love it, of course.
The residual shunt is a big issue in the future follow-up for this kind of patients, and majority of the patients have initially complicated for the septal aneurysms, or that maybe we need a larger device. Even we select for the larger device, the residual shunt still exists. So that is.
I think if the device is larger, that does not reduce the risk of residual leaks. Sometimes it increases the probability of a leak. And that is if the device is then pushed away from the aortic root or from the septum secundum, then actually the device is that kind of configuration. And then you have shunt in between the two parts of the device. So I always go, that's one of the reasons why I always go for the smallest device, because then that risk that it gets apart is reduced. The two umbrellas are closer together and the likelihood of complete closure is better. And so I think we should not try to cover the aneurysm.
That is a good idea. And the very rarely I take the transesophageal echocardiography. Patient have the during the follow-up, 1 year follow-up after patient with residual shunt, in the bubble closing about between the septum and the device. That is some small tunnel, still not complete endothelialization. Most of the
that
septal
happens,
aneurysms.
and that probability increases when you use bigger devices. And I think we will have a case during this CSI to show how to close these leaks.
Is there any questions from the audience? Okay.
I think we can move on. Thank you, Urs.
Thank you very much.
So